So we are live now.
Good evening, all. This is Rupesh, sports physiotherapist from Peak Health Studio, Chennai. A warm welcome to all of you for the ExRxIndia presenting for the students by the students webinar series. I thank Dr. Chandramohan from Sri Samraj Health Service Private Limited and founder of ExRxIndia, and Sampath Kumar, CEO of Sri Samraj Health Service Private Limited. Then Professor Duna from Dusat Creations for her continuous and tireless support for this program, ExRx India for the students by the students webinar series. I thank all the future physiotherapy graduates for supporting for this program. And this is not a competition, but this is to bring out to build your confidence for public speaking. Today's first topic is presented by Ms. Twinkle Gera from Jagannath University on the topic breathing exercise. Ms. Twinkle, you can take over.
Yes. Good evening, everyone. Myself, Twinkle Gera from Haryana, Rohtak. I'm presenting you the topic breathing exercise. So let's dive in. First of all, let me explain the mechanism of breathing. So when we inhale, the external intercostal muscles present between the ribs contract, pulling the ribs, by which ribs make an angular movement, expanding the thoracic area. So at the same time, diaphragm present below the lungs also contract, increasing the thoracic area. As the thoracic area increases, the negative pressure between the pleural membrane force the lungs to expand. As a result, the air through the nasal cavity and the bronchus pushes inside the lungs, filling the alveoli with oxygen. Fresh O2 then diffuses into blood vessels through the alveolar walls. At the same time, carbon dioxide also diffuses from the blood vessel into the alveoli. When we exhale, the diaphragm muscles are relaxed and diaphragm returns to its normal structure. This decreases the thoracic volume. The internal intercostal muscles contract, making ribs to return back to their normal position. This also decreases the thoracic volume. As the thoracic volume decreases, the lungs are forced contracted. By this, the air in alveoli are pushed outside through the bronchioles, bronchus, and finally out by nasal cavity. This is the whole breathing mechanism. Now, breathing exercise. Why we use breathing exercise? These exercises are designed to retain the muscles of respiration and improve ventilation and improve gas exchange and oxygenation. Incorporated into the overall pulmonary rehabilitation program or patient with chronic pulmonary disorder. We basically use these exercises for patients with chronic pulmonary diseases. Next, helps to expand the chest, facilitate deep breathing, and stimulate the cough reflex. These exercises often combined with medication, postural drainage, the use of respiratory therapy devices. Some of the respiratory therapy devices like spirometer. Indication of breathing exercises. First, acute or chronic lung disease. The major important one is chronic obstructive lung disease, that is COPD. We all know about this. Pneumonia, pulmonary embolism, acute respiratory diseases like cystic fibrosis, bronchiectasis, lung abscess, neuromuscular diseases. For the patient with high spinal cord lesion, like spinal cord injury, myopathies, etc. History of pulmonary problems, and after surgeries like thoracic or abdominal surgery, we most of the time we prescribe them breathing exercise. Airways obstruction due to retained secretions for the patient who must remain in bed for an extended period of time, like I already told, the patients with spinal cord injury, as relaxation procedure. Goals of breathing exercises. What basically breathing exercises do? Improve ventilation, increase the effectiveness of cough mechanism, prevent pulmonary impairments, improve strength, endurance, and coordination of respiratory muscle. maintain or improve chest and thoracic spine mobility, promote relaxation, teach the patient how to deal with shortness of breath attacks, improve patient's overall functional capacity. Guidelines for teaching breathing exercises. First, choose quiet area for instruction where interaction between you and the patient with minimum distraction. We have to choose the quiet area so that we can discuss whole mechanism with the patient. Next, explain to patient. We have to explain the aims, impairments, and functional limitation about breathing exercises to the patient. Patient must be comfortable, relaxed, and loosen restrictive clothes. He must be with loosened clothes so that he can breathe comfortably. Initially, semi-Fowler's position with head and trunk elevated approx 45 degree. Supporting the head and trunk, hips should be flexed, knees should be flexed, legs supported with pillow, abdominal muscles will be relaxed. Other positions such as supine, sitting, or standing may be used. Observe and assess the patient's spontaneous breathing pattern. Determine whether ventilatory training is indicated. Relax the muscle of upper thorax, neck, and shoulder to minimize the use of accessory muscles of ventilation. Attention to relaxation to the sternocleidomastoid. These muscles should be relaxed, like sternocleidomastoid, upper trapezius, and levator scapula. Describe breathing pattern to the patient. Precautions. What precautions we should use? Never allow patient to force expiration. Forced expiration only increases turbulence in the airway, leading to bronchospasm and increased airways restriction. Do not allow patient to take a prolonged expiration. This causes breathing pattern become irregular. Advise the patient that the upper chest should be relatively quiet during breathing. Allow the patient to perform deep breathing for only 3 or 4 inspiration and expiration at the time to avoid hyperventilation.
Yes, ma'am.
Now, contraindications. Unstable head or neck injury, active hemorrhage with hemodynamic instability, recent spine injury, emphysema, bronchopleural fistula, flail chest, uncontrolled hypertension, ribs or vertebral fracture or osteoporosis, acute asthma or tuberculosis. Patient have recently heart attack. Patient with skin graft or spinal fusion will have undue stress placed on areas of repair. Bony metastasis, brittle bones, bronchial hemorrhage are contraindication for undue stress to the thoracic area. Verify that patient has not eaten at least 1 hour. Severe obesity, recent meal or tube feed, or you can say tracheostomy, untreated pneumothorax, and chest tubes. Now, breathing exercise or methods of breathing. First breathing pattern is diaphragmatic breathing. The diaphragm is the main muscle of breathing. It is supported to do most of the work. When you have COPD, the diaphragm doesn't work well, and muscles in the neck, shoulder, and back are used. These muscles do not much to move your air. This technique is best used when you are feeling rested and relaxed while sitting back or lying down. How we perform? You can see here. Relax your shoulders. Place one hand on your chest and other on your belly. Inhale through your nose for about 2 seconds. As you breathe in, your belly should move outward. Your belly move more than your chest. As you breathe out slowly is through pursed lip. Pursed lip position I'll explain later, but here you know that like we do like this. This will push up on your diaphragm to help get your air out. We have to repeat like for 5 minutes, 10 minutes. We can do either in lying position, either in standing. How we re-educate the diaphragm. As other skeletal muscle, diaphragm also shares property of skeletal muscle. So diaphragm has a property of skeletal muscle. Place the index finger below the costal margin anteriorly in half-lying position over the insertion of diaphragm. At the end of expiration, when diaphragm is relaxed, so we are doing this in expiration. Stretch stimulus is given to the diaphragm to elicit the stretch reflex of the diaphragm, and patient is instructed to breathe in. Resisted diaphragmatic breathing. Manual resistance by therapist over the abdomen. Either therapist put his or her hand on the abdomen of the patient, or we place some appropriate weight over the abdomen by slightly elevating the foot end over the bed. Procedure same as breathing exercise, normal breathing as we do. That's how we perform resistive diaphragmatic breathing. Now, segmental breathing. Basically, it is performed on segments of the lungs or a section of chest wall that needs increased ventilation or movement. Hypoventilation doesn't occur in certain areas of the lungs because of pain and muscle guarding after surgery, atelectasis, and pneumonia. Therefore, it will be important to emphasize expansion of problem areas of the lungs and chest wall under certain conditions. What are the indications of segmental breathing? Post-thoracotomy, trauma to the chest wall, pneumonia, post-mastectomy scar, or you can say breast surgery, post-chest radiation fibrosis. Segmental breathing can be performed by different ways. Number one, lateral costal expansion. This is sometimes called lateral basal expansion and may be done unilaterally or bilaterally. So lateral costal is the segment of the lungs. Patient may be sitting or hook lying position. Place your hand along the lateral aspect of the lower ribs to fix the patient's attention to the area which movements is to occur. Ask the patient to breathe out and feel the rib cage move downward and inward. As the patient breathes out, place firm downward pressure into the ribs with the palms of your hand. Just prior to inspiration, apply a quick downward and inward stretch to the chest. Place a quick stretch on the external intercostal to facilitate their contraction. These muscles move the ribs outward and upward during inspiration. Apply gentle manual resistance to the lower rib area to increase sensory awareness as the patient breathes in and the chest expands and ribs flare. Then again, the patient is breathed out, assist by gentle squeezing the rib cage in a downward and inward direction. B. Right middle lobe or lingual expansion. Number one, patient is sitting. Place your hand right or left side of the patient's chest below the axilla. This is the position of the right middle lobe of the lung. Follow the same procedure as described for lateral basal expansion. C. Apical expansion. Patient is sitting. Apply the pressure below the clavicle with the fingertips. This pattern is appropriate in an apical pneumothorax after lobectomy. See, you can see here first is apical position, second is upper costal, other one is lower costal, then sternal and posterior costal. We apply this from the back. Next is glossopharyngeal breathing. Glossopharyngeal breathing is a mean of increasing a patient's inspiratory capacity when there is a severe weakness of the muscle of inspiration. Today, if it is used at all, it is most frequent taught to the patient with high spinal cord injury who can develop easily respiratory problems. So basically, we prescribe these exercises in patients with spinal cord injury. Procedure: patient take gulps of air. Then mouth is closed and the tongue pushes the air back and traps it in the pharynx. The air is then forced into the lungs when the glottis is open. This increases the depth of inspiration and the patient's vital capacity. Other one is pursed lip breathing. Slow your breathing down, keeps airways open longer so your lungs can get rid of more stale and trapped air. Reduce the work of breathing, increase the amount of time you trapped air. Increases the amount of time you can exercise or perform an activity. Improve the exchange of oxygen and carbon dioxide. To do pursed lip breathing, first breathe in through your nose for about 2 seconds. Pucker your lips like you are ready to blow the candles on your birthday cake. Breathe out very slowly to pursed lip 2 or 3 times as long as you breathe in, and we have to repeat it. You can see here. Belt exercises. Length, uh, you can take any belt. Basically, uh, the length should be 2 meters, width 30 centimeters. Advantage: after operation, as it make equal pressure in all points and take a larger area, so its pressure become not painful, which is more suitable for operative cases and fatty subjects. Easy to be used by everyone who can manage themselves. Disadvantages or contraindications: frequent movements are difficult to be noted, cannot be used for small and irregular areas. Exercises to mobilize the chest. This can give mobilizing, strengthening, or stretching exercises connected with respiration or expiration. Upper limb and lower limb. Abduction, extension with inspiration. Adduction, flexion with expiration. And if we have to do that for trunk, bending forward, or you can say flexion with expiration. Bending backward with inspiration. Turning trunk with expiration. These are the exercises to mobilize the chest. As you see here, exercises of the lower limb connected with breathing. Patient is lying on and the therapist is nearby him. He should be in comfortable position, and with breathing pattern, he can mobilize his upper limb as well as lower limb and even back also. Now, earlier I was talking about cuff mechanism. So here we go and talk about cuff mechanism. An effective cuff is necessary to eliminate respiratory obstruction and keep the lung clear. It is important part of treatment of patient of chronic or acute respiratory conditions. Cuff mechanism. Deep inspiration occur, glottis close, and vocal cord is tightened. Abdominal muscles contract and diaphragm elevate, causing increased intrathoracic and intra-abdominal pressure increase. Glottis open, explosive expiration of air occur. The factors that decrease the effectiveness of the cuff mechanism. A. Decrease inspiratory capacity because of pain, acute lung disease, rib fracture, recent thoracic or abdominal injury, spinal cord injury, anterior horn cell disease, etc. B. Inability of the patient to forcibly expel air as the result of number 1, muscular dystrophy, chest wall or abdominal incision, critical illness that cause excessive fatigue. C. Decrease action of the cilia in the bronchial tree, secondary to intubation and general anesthesia, COPD, that is chronic obstructive pulmonary disease, smoking. D. Increase the amount or thickness of mucus caused by cystic fibrosis, chronic bronchitis, pneumonia, dehydration, and intubation. These all are the factors which is responsible in deteriorating the cough mechanism, or you can say slow down the cough mechanism. Teaching an effective cough. Evaluate the patient's voluntary or reflex cough. Place the patient in comfortable position. Teach the patient controlled diaphragmatic breathing, deep inspiration. Demonstrate a sharp, deep, and double cough. Demonstrate the proper muscle action of coughing. Patient place the hands of the abdomen and make 3 puffs with expiration to feel the contraction of the abdominals. Patient practice to making a K sound to experience tightening vocal cord, closing the glottis, and contracting the abdominals. Use glossopharyngeal breathing in selected patients. Precaution: never allow the patient to suck air in by grasping because it pushes mucus or foreign object deep into the air passage. Increase resistance in the airways. Additional means of facilitation a cough. Number 1, manual assisted cough. If the patient has abdominal manual pressure on the abdominal area, will develop intra-abdominal pressure. Procedure: therapist assisted. Patient in supine position. The therapist placed the heel of the hand on the patient's abdomen at the epigastric area, just distal to the xiphoid process. The other hand placed on the top of the first. After the patient inhale as deeply as possible, the therapist manually assists the patient to attempt cough. Abdomen compressed with an inward and upward force. Therapist can stand back of the patient and apply manual pressure during expiration. Self-assisted, how patient can do by himself. While patient in sitting position, he will crosses the arms across the abdomen or places the interlocked hand below the xiphoid process. After a deep inspiration, he pushes inward and upward on the abdomen with the wrist or forearm and leans forward while attempting cough. Splinting. If incision pain from the recent surgery is restricted, the cough teach patient to splint over the incision. Patient press the hands or a pillow firmly over the incision to support the painful area as he cough. If the patient cannot reach the incision, the therapist should assist. Humidification. If secretion are very thick, work with the patient after humidification therapy and ultrasonic nebulizer therapy. Both enhances the mucociliary transport system and facilitate a productive cough. Quote, tracheal stimulation. It is called tracheal tickle, may be used with infants or disoriented patients who cannot cooperate in the treatment. The therapist places 2 fingers at the sternal notch and applies a circular motion with pressure downward into the trachea to facilitate a reflexive cough. Precautions: avoid uncontrolled coughing spasm. Avoid forceful coughing with patients who have a history of cardiovascular accident. Be sure that the patient coughs while in somewhat erect posture. Next, we move to manual therapy and postural drainage. Definition. What basically postural drainage is? Postural drainage is a technique in which different positions are assumed to facilitate the drainage of secretion from the bronchial airway. Gravity helps to move the secretion to the trachea to be coughed up easily. The goals of postural drainage and manual therapy is to help drain mucus from each of these lobes into the larger airways to the lungs so it can be coughed up readily. Goals of postural drainage: prevent accumulation of secretion. Patient who have prolonged bed rest, post-surgical patient, remove secretion already accumulate in the lungs. COPD, acute or chronic lung disease, pneumonia, patient with artificial airways, contraindication, hemorrhage, that is blood in sputum, Untreated acute condition like severe pulmonary edema, congestive heart failure, pulmonary embolism, pneumothorax, cardiovascular instability like cardiac arrhythmia, severe hypertension or hypotension, recent myocardial infarction, recent neurosurgery, head down position may cause increased intracranial pressure. Technique used during postal drainage. First, percussion. Chest percussion, also referred to as chest physiotherapy, is an airway clearance technique that involves clapping on the chest. The position like this. We have to make our hand position like this. Doing this make cough mucus easier to expel or cough up. Chest percussion is often coupled with postal drainage and vibration and can be performed using either cupped hands or mechanical airway clearance device. Vibration. Vibration is an airway clearance technique that, coupled with chest percussion, is applied during postal drainage to help clear mucus from the airway. Vibration helps to gently shake mucus and secretion into the large airways, making them easier to cough up. During vibration, place your flat hand firmly against the chest wall. Atop the appropriate lung segment to be drained. Stiffen your arm and shoulder, apply light pressure, and create a shaking movement similar to that of a vibrator. Ask service user to breathe in deeply during vibration therapy and exhale slowly and completely. Take a deep breath and then exhaling slowly and forcefully without straining will hopefully stimulate a productive cough. Shaking. Shaking is more vigorous form of vibration applied during the exhalation using an intermittent maneuver coupled with wide movement of the therapist's hand. Postal drainage position. Position is based on the anatomy of lungs. The patient may be positioned on a postal drainage table, tilt table, reinforced padded table with a lift, hospital bed. A small child can be positioned on the therapist's lap. You can see the position here for the segmental breathing or postal drainage for different lobes of lungs. Indication and contraindication. Indications: chest infection, cystic fibrosis. Contraindication: bruises on skin. Thank you. It's done.
Yeah, well presented, Miss Twinkle. So, with short period of time, you have explained about all the types of breathing and everything clearly and calmly. Actually, it was pleasant hearing you. So, I take this honor to thank the HOD of your college, Dr. Ravindra Kumar Mugdil, sir, and I appreciate his encouragement towards the students' presentation in this program for the students by the students series. So, thank you, and we'll meet soon in our future sessions. Bye bye.